Okay, it's 1 minute past 5. I would like to warmly welcome you again after a break for the Astro meeting to our virtual grand rounds on radiation oncology. Many thanks for joining for our symposium or meeting, which is happening every month on Wednesday, the first Wednesday in the month between 5 and 5:30. And you know the format. We aim to present you the latest science presented by the top speakers which have been involved in the generation of these clinical trials, and that in a very interactive format. So if you have any questions, and I'm very confident there will be many, please ask them using the question and answering functionality. Also, many thanks again, as usual, to our supporting societies, Estro, Sastro, and Degro. Many thanks for endorsing and for advertising our symposium. Also, a reminder, this is not the first meeting, but all symposia, all meetings are being recorded. They are on the meeting homepage. So if you want to go back and look at the past presentations, please have a look and enjoy the fantastic presentations of these colleagues which have been given in the last weeks and months. With that, I would like to come to today's clinical trial, very important for our discipline, the Keynote 412 trial, which evaluated the addition of pembrolizumab to concurrent chemoradiotherapy in locally advanced squamous cell carcinoma of the head and neck. It has been a randomized phase 3 trial, and we have seen positive results in some tumor entities for the addition of immunotherapy, but we've also seen negative results, and unfortunately, this trial has been negative, and that is why I'm very happy, very honored to present the speaker of this seminar, Professor Vincent Grégoire. You all know him very well. He's the head of the department of the Lyon Cancer Center in Radiation Oncology. He's very well known to the field of head and neck cancer and radiation oncology, having established the consensus guideline for target volume definition, having been Astro president, having been on the board of the EORTC, chairing the head and neck radiation oncology group, and also chairing the ICLU. Today, we not invited you for this work which you have been done before, but because you've been fundamental in the development and in the execution of the Keynote 412. And we are very happy to invite you, to welcome you, and hopefully enlightening us why this trial has been negative, potential explanations, and potential, ideas how to design the next generation of clinical trials to move us forward. Vincent, many thanks for coming here, and the floor is yours.
Thank you very much, Professor Guckenberger, for your very nice introduction. It's a pleasure to share with you what I know about the trial and how to put it into some perspective to avoid or to try to learn from the mistakes, and for sure avoid repeating, maybe not a mistake, maybe a suboptimal design, let's call it like that. First, you may say, why do we want to combine radiation with immunotherapy? This is a very old, quite old now, and well-known slides to you, the so-called immunity cycle, where we have some release of tumor antigen, which are taken by cancer antigen presentation, the typical dendritic cells. The dendritic cells bring the antigen to the neighboring lymph nodes. They activate the T cells. The activated T cells go back into the bloodstream and find back the tumors and start doing some cell kill. And we know that radiation, by killing cells, will release tumor antigen, will release some calreticulin, free DNA, and all proteins or substances that will typically be taken off by the dendritic cells and activate an immune response. So obviously, there was plenty of rationale to combine radiation with immunotherapy. Some of you may not be aware that it's working. This is one example among many examples. It's a palliative example, I agree. In picture A, you see a gentleman who benefited from surgery and post-op ionizing radiation, and unfortunately, he presented a local recurrence. Excuse me. And in B, he started with chemotherapy, and as you can see, there was absolutely no response with palliative chemo. In C, the team in Japan decided to start an immune therapy challenge. And as you can see in C, it did not work at all. The tumor in C is even bigger than in the tumor in B. And in D, because the patient was extremely painful, he received 30 grays in 10 times 3 grays. And you see a complete disappearance of the tumor, a complete response. So what's happened? Maybe radiation helped releasing tumor antigen that activate this immune cell cycle. So it makes sense to combine the two, not on a palliative setting, but on a curative setting. And this is the keynote 412 trial, which is a randomized phase 3 trial, where basically patients with locally advanced head and neck cancer, mainly oropharyngeal, laryngeal, hypopharyngeal, and oral cavity. It was P16 negative and P16 positive oropharyngeal, but properly stratified. Patients were randomized between concomitant chemoradiation with pembrolizumab during concomitant chemoradiation and as a maintenance for almost a year, for 14 cycles, or the placebo with concomitant chemoradiation and then a maintenance with 14 cycles of a placebo. And it was cisplatin-based concomitant chemo radiation. The standard radiation was either 6 weeks or 7 weeks, so slightly accelerated or normally fractionated radiation with typically 2 gray per fraction. Interestingly, and because we'll come back to that, in the 2 arms of the study, there was similar expression of PD-L1 between the 2 arms. Also, it might be important for the discussion, there was similar fraction of HPV positive among the 2 arms of the study. And I don't have time to read all the details, but there was a good balance between the different factors, patient characteristics, baseline patient characteristics between the 2 arms of the trial. Interestingly also, the treatment was properly done, or the treatments were properly delivered. If you see the median dose of radiation, 70 gray in both arms, the overall treatment time was quite totally acceptable. And as you can see on the right part of the picture, an adequate dosage of cisplatin were given either between 200 and 300 milligrams per square meter for half the patient or above 300, which means centers who decided to give 3 courses in 7 weeks compared to centers who were only able to give 2 courses, but in 6 weeks of slightly accelerated radiation. And as you can see, there was no imbalance between the pembro plus concomitant chemo or the placebo plus concomitant chemo radiation. So pretty well conducted trial. And so when you look at the primary event, which was the event-free survival, the primary endpoint, excuse me, of the study, you see a non-significant difference between pembro plus concomitant chemoradiation in green and placebo plus concomitant chemoradiation in red. I ask you not to ask me about the statistical design, excuse me again, but because of the design, which will be difficult for me to explain, the p-value needed to be 0.025 to be significant. So there was a trend, but we cannot say that this is statistically significant. If you look at why was it, or what was the effect observed, you can see that there is almost a similar local regional relapse among the 2 arms. Pembro plus concomitant chemo 13.2%, placebo plus concomitant chemo 14.2%, but a much lower distant metastasis relapse, 13% for pembro plus concomitant chemo and almost 17% for placebo plus concomitant chemo. So it may it looks like that the slight effect, although not significant, was maybe due to reduced metastasis rate in the pembro plus concomitant chemo. When you look at the pre-specified subgroup, as you see, nothing really came out at least significant. Maybe, except maybe that the patient with a high PD-L1 CPS score did slightly better in the pembro plus concomitant chemo arm compared to placebo plus concomitant arm, and compared to those with a lower CPS score less than 1. So maybe CPS might be of interest as a surrogate to select those patients that might benefit of immune therapy on top of concomitant chemo radiation in that particular patient population. This is the overall survival, as already mentioned, showed by Matthias Guckenberger, strictly no difference between the two arms, as you can see on this picture. In terms of side effects, the good things to say is that the use of pembro on top of concomitant chemo did not really alter the toxicity with almost similar range of grade 3-5 and a similar range of grade 5 toxicity between the two arms. So toxicity or safety-wise, we cannot say that the use of pembro was detrimental to the trial, which might have maybe expected or explained, excuse me, not expected, explain the lack of efficacy. No, it is not because of that. So the summary of the trial is that there is a small difference, but because of the design, it did not reach the p-value of 0.025, so it cannot be considered as a positive trial. And even if it's positive, the small difference was quite low, sorry, compared to what was expected. And the conclusion of the main author, which was Professor Matthias, that I thank because I got quite a lot of slides from his presentation at the last European meeting. So the question that we may ask, is this the only negative trial in the field of concomitant chemoradiation plus immune therapy? As you know, some years ago, two or 3 years ago, the Javelin head and neck 100 trial was reported, randomization between avelumab and concomitant chemoradiation or placebo and concomitant chemoradiation. And as you are all familiar with, the primary endpoint, progression-free survival, was not different, and even in disfavor of the avelumab plus concomitant chemoradiation. I should have mentioned that there was also a maintenance phase of avelumab for 12, every 2 weeks for, I think, 6 months, if I remember well, in that particular trial. So a second negative trial. Is these 2 trials the only negative? Unfortunately not. You may know that the Cortec REACH trial has been published, also at least reported, for the unfit patient for cisplatin. So it was cetuximab or avelumab plus cetuximab and radiation on the left part of the trial. And the difference is not significant, again, although there is a trend. And for patients fit for cisplatin, so it was avelumab cisplatin compared to avelumab cetuximab, and there was no difference between the 2 arms of the study. And then the last one that I found, at least, is the pembro, again from Cortec, where patients were randomized with pembro during radiation compared to, again, radiation and cetuximab. There was, as you will see, no difference whatsoever between the one so-called standard of care. I said so-called because for me, it's not a standard of care. You may disagree with me, but I say so. And a new trial, which is radiation and pembro. So I think we need to say that all trials have been so far negative, while the prospect and the rationale was highly intelligent and highly in favor of the combination between radiation or chemoradiation and pembro. Why is it so? First, as already mentioned, maybe subgroup analysis revealed that the patient with a high CPS score did better than the one with a low CPS score. And what you see on these slides is the difference between overall survival and event-free survival for the patient with a CPS score more than 1. So maybe a slightly better effect for the event-free survival, and even a bigger effect when you look at patients with CPS more than 20. So maybe the CPS score might be a way to pre-select those patients that might benefit to a larger extent from the use of immune therapy combined to concomitant compared to a placebo during concomitant chemo radiation. I should have said, so this is the summary of the Jean-Pascal Makil's trial, that maybe the CPS score might be another way to do it. The Javelin study, when they look at it, they also look at the bottom part of the picture again. Those with a PD-L1 expression did slightly better when avelumab was combined with concomitant chemoradiation for this locally advanced squamous cell carcinoma of the head and neck. I should have said that I forgot to put the slide. There was a similar conclusion for non-small cell lung cancer when it was given apart from concomitant chemoradiation. Pacific trial was highly positive. When it was given concomitantly to concomitant chemoradiation, it was also a negative trial. Why is it so? We know that radiation on the left part of my slide is highly immunogenic. I already mentioned it to you. I even show you an example. But we also know that radiation is highly immunosuppressive. And as you know, they are in the field of head and neck, but also in other diseases, lung, GI, as far as I know, that patients with grade 4 lymphopenia during radiation are doing much worse than patients without grade 4 lymphopenia. So to have a low count of lymphocytes, probably including tumor-killing lymphocytes, was obviously or is obviously a detrimental factor. But why should we see lymphopenia during radiation for the field of head and neck? I guess you are all aware that typically, I said typically, for locally advanced disease, we irradiate both sides of the neck because they are lymph nodes, therapeutic lymph nodes on one side, prophylactic lymph nodes irradiation on the contralateral side. And it's likely, it's an hypothesis, it's likely that by doing so, we kill, at least in the neighboring space of the primary tumor, we may have killed all the T cells, all the lymphocytes that may be needed to trigger an immune response. And in that field, we have designed a trial where patients will be randomized for the unilateral primary tumor, not crossing the midline, and verifying with an FDG PET the negative neck on the contralateral side. Patient will be randomized between unilateral and bilateral treatment, and there will be 2 additional arms where we will trigger the immune response by giving all-trans-retinoic acid, and all-trans-retinoic acid is in fact a compound that will mature the myeloid-derived suppressor cells and restore an adequate balance between the CD8 lymphocytes and that stimulate an immune response and the myeloid-derived suppressor cells that will depress the immune response. So obviously, this is the end of my presentation. Basically, in summary, all the trials so far has been negative, including the latest one, the 412. And I gave you two explanations. One might be that we may have to select patients who may be most likely to respond. And maybe a second is that we may have to rethink the target volume to try to really benefit from the most of what each modality, radiation on one side and immune therapy on the other side, could provide us. With that, I would like to thank you very much for your kind attention.
Many thanks for an excellent presentation, and for the discussion, I would like to hand over to Professor Balampas, who's leading our head and neck service here at the University Hospital Zurich. So Panos, please.
Vincent, thank you very much for this excellent talk, especially that you managed to put so many topics about this study in only 20 minutes time. We have two questions that have been partially answered. I will come back to them, but maybe first from my side, you showed that the locoregional control was similar in both arms. And what about the data that were presented last year from Dan Zandberg from Pittsburgh, who changed only the timing of the application of immunotherapy and radiotherapy, and he showed a large difference in locoregional control rate?
Yeah, so what may also be an avenue for the future is to combine immune therapy either before local or local regional radiation or concomitant chemoradiation, before and or after. So not during the same time, assuming that after some time you will still have enough local immune effector cells to trigger and to stimulate an immune response. So in other words, do a sort of window of opportunity or induction immunotherapy and adjuvant immune therapy, but not combining the two together. This was in fact the Pacific 1 trial, if I remember well, where immune therapy were given after local treatment and not during local treatment, while the Pacific 2, it was given during and after, and then it became a negative trial because the trial was simply stopped by anticipation because of no positive, no benefit during an interim analysis. So this would be my answer to your question, Panos.
Thank you. And we refer now to the CPS score for selection of patients, to the timing, and to the nodal sparing. One question from the chat is, are there any other biological reasons maybe that come into your mind for not working?
Yeah, as you know, in the field of head and neck, hypoxia is an issue. And we know that hypoxic environment, it's not an easy environment, not a pleasant environment to stimulate an immune response. So the fact that we might have, at least in the primary tumor, maybe also in the lymph nodes, quite a lot of hypoxia may also be a detrimental microenvironment to stimulate an immune response. This is something that comes on top of my mind after you ask me the question. And I'm sure there are plenty of unknown, for sure unknown to me, but also maybe totally unknown reasons why this is not properly working. But at least it shows that, as I mentioned in one of my my slides from Oscar Wilde, we have a limited knowledge of what we do, although we believe we have a large knowledge, but it's not true. We still have a lot to learn, especially in the field.
That is true. And the second question from the chat, maybe then we are shortly from done. Olgun from Bern asked if you will welcome a phase 2 or 3 trial with reduction or omission even of elective nodal radiation. I think you indirectly answered this with your great study design. some years ago, it was not so wide accepted in the community. Maybe to adapt this question a bit, do you think a combination of immune checkpoint with cisplatinum or with retinoic acid maybe to enhance, what could work the best?
I simply don't know. Let's put it clearly, I simply don't know. And I think nobody knows. There are so many factors involved in stimulating or enhancing an immune response. And we cannot know, we don't know at least right now, which one is the most effective. So it's only by doing either phase 2, randomized phase 2 or phase 3 trial that we will learn and try to figure out, okay, what is the best? So I'm afraid I cannot answer your question. The only thing I can say is that we need to remain modest because our knowledge is not as broad as what we would like to have or as like we believe we have. No, so we do not have a so broad knowledge in the field.
I would also have one additional question. We have seen the Adriatic trial being presented at the ASCO meeting, small cell lung cancer, limited stage disease, where the maintenance durvalumab was also resulting in a quite substantial benefit, which was, to me, unexpected, even larger as compared to the extensive stage disease, where the benefit of immune checkpoint inhibition was there, but kind of modest. And there was some discussion being held whether it was the tumor volume which might have an influence. Have you done any subgroup analysis? Are you planning it in Keynote? Have you recorded the tumor burden, tumor volume, whether this might be a factor affecting it? I've not seen such an analysis in lung cancer because in the pharma-driven trial, it's usually not recorded.
That's a good point. It's a good point. And indeed, in radiation, it has been shown to be a detrimental factor. I'm not, I have to admit, I don't know if we recorded the tumor volume in the Keynote trial. This is something I may want to ask to Jean-Pascal Mackils and see whether we could do the analysis. Having said that, maybe I should not say it, but I will say it anyhow. The trial was company sponsored. Whether the company will be willing to give access to the data they may have, it's something which also might need to be asked first before we try to do this analysis, which may make sense, by the way. Indeed. Another point, Matthias, is that head and neck is not lung, and lung is not melanoma, and melanoma is not kidney disease. So although it's cancer cells, of course, and even between lung and head and neck is squamous cell, the immune behavior is totally different between a lung squamous cell carcinoma and a head and neck squamous cell carcinoma. That's also something that we need to recognize, when designing clinical trials.
I don't see any other questions. Thank you very much again, Vincent. This was really, really a very good overview for us all. And I give to Matthias Guckenberger to announce the next meeting.
Yes, I'm very happy to announce the next iteration of our virtual grounds, but also want to take the opportunity to thank you, Vasa, for an excellent presentation, for contributing to our series. The next question we want to address is, do we need to give all our patients, our prostate cancer patients, in the salvage setting and antigen deprivation therapy? You've seen the results of the Radicals HD trial being presented just a few days ago in the Lancet. There was 3 arms, no ADT, 6 months ADT, and 2 years ADT. And many of you have seen the results of a benefit for metastasis-free survival, which was the primary endpoint for the long-term ADT. So the question is that a new standard of care? How do we select patients? And I'm very happy to announce that Professor Chris Parker, the PI of this trial, who was also the PI of the Radicals RT trial and the Stampede arm, will present the trial on July 16th at 5 o'clock. You may notice that July 16th is not the very first week in the month, so we had to adjust our schedule, but we want to stay in our kind of sequence, and therefore we will present something differently. ASCO is up and running, and you heard a couple of trials which potentially change the practice of radiation oncology. And we want to do some critical appraisal from radiation oncologists and for radiation oncologists, addressing trials like LAURA, like ADRIATIC, ESOPEC, or the sarcoma trial. So join us on July 3rd, again, the first Wednesday of the month, 5 o'clock, half an hour for critical appraisal of this potentially and most likely practice-changing trial. With that, I would like to thank you for joining us again today. Wish you a good evening, and while hopefully seeing you again in 4 weeks' time. Thanks a lot.
Thank you for inviting me. Have a good evening to all of you.
Good evening.
Thanks a lot. Have a good evening, Marcel.
Bye-bye.
Bye.